Meet Dr. B, a primary care physician. Dr. B sees two patients, Chloe and Zoe. Chloe and Zoe have almost identical health profiles. For example, they're the same age, height, and weight. They even have the same blood type. Chloe and Zoe take part in similar activities and have little to no risk for conditions such as diabetes or cardiovascular disease. They also belong to the same socioeconomic class, live in the same type of neighborhood, and have good access to healthcare services. For medical purposes, Chloe and Zoe are essentially the same person. Yet, when Dr. B does some routine tests on them, Chloe and Zoe get very different results. While Chloe's results lead to Dr. B engaging more with her and suggesting screening and other preventative services, Zoe is sent home with no further tests. But why? The only difference in their health profiles is their race. The reason is that Chloe and Zoe's results are influenced by racialized medicine, a common practice in U.S. healthcare. Racialized medicine is when doctors and researchers consider a person's race as a key factor that can define their health. For example, they may use medical devices, measurements, and algorithms that account for race in their calculations. It can result in race-based research agendas, shape diagnosis and decision-making, and impact the type of care that patients receive. The feeling of being treated differently can also impact patients' mental health. Let's look at an example of racialized medicine. The National Cancer Institute has a calculator that estimates the risk for people developing breast cancer who do not have a prior history of the disease. However, the calculator gives lower risk estimates for people who are Black, Hispanic, or Asian American, which could discourage these groups from going for regular screenings. The problem with racialized medicine is that it wrongly assumes that race in humans is a biological reality. Race in humans is socially defined, which means it is a concept invented and generally accepted by a society. Overall, different socially defined racial groups experience different health outcomes not because of genetic differences, but because of historical inequalities that still exist today. These include less access to certain resources such as housing, education, or healthcare. When medical professionals practice racialized medicine and make different suggestions according to a patient's race, they are contributing to a racial health inequity. As we confront racial injustice in the medical field, a growing number of doctors, researchers, and patients are arguing that racialized medicine is not evidence-based and promotes racial bias and unequal healthcare. As we saw with Chloe and Zoe, Chloe received extra medical attention while Zoe did not. Even though they have near identical health profiles, Chloe was privileged to receive further screening and testing because she is white. Dr. B, who is dedicated to promoting equity in her medical practice, makes an effort to learn about how deeply rooted racialized medicine is in U.S. healthcare. She stops using race-based methods and tests that leave racially marginalized communities vulnerable. Dr. B considers Zoe's individual needs and recognizes racism, not race, as a determinant of health. By doing so, Dr. B takes an important step toward health equity.